So they look a bit like the continuation sheets that you all fill out, yeah. And then we've just got a random jog chart that I put together in 2 seconds this morning. Okie dokies. So this is the usual OSCE mannequin of Tina Neal. Yeah. So upon receiving her in Paku, I will just listen to the scenario. So you guys will be listening to the scenario that I give you, yeah? Okay. So we will say that this is Tina Neal and she is a post-operative laparoscopectomy patient. It was elective surgery. She was an ASA2 due to hypertension, yeah? She had propofol and danazotran fentanyl on induction. There was no issues with her blood pressure during theatre. She didn't require any matrolinol. It was uneventful surgery. She's currently on a Hudson mask of 6 litres, because let's face it, all of them would be, because they're post-op. It's the weirdest Hudson mask ever, but that will do. There we go. Okay, and I've been asked to take over her care. Yeah? Do you want to shut that door for me, please? So the first thing I'm going to do is conduct my A to E assessment. Okay? So for airway, I'm looking and I'm going to speak to her, because if she's speaking to me, we know that airway's okay. Yeah? So Tina, how are we doing? So she's a little bit groggy, but she's speaking to me, so I'm happy. She's on 6 litres of oxygen on a Hudson mask, but she's talking to me, so I'm happy with airway, so I'm going to move on. That's simple, yeah? Again, your OSCE's not going to be overcomplicated. I'm not going to make them have airway obstructions, etc., etc.
Yeah, I'm worried with you.
I'm not going to be mean, all right? But if they did, you all know how to do it. Anyway, I drilled it into you, head tilt, chin lift, or an airway adjunct. Yeah? You know what to do if I do decide to be mean on the day, which I won't, so it's fine. I might today, but we won't on the actual day. Alright? So then we're going to need to do our breathing assessment. Now to do that, we need to expose Tina's chest. And I cannot stress this enough. You cannot do a full airways breathing assessment if you don't expose the chest. So the first thing I'm going to do is say, Tina, are you happy for me to just expose your chest for the minute? I've got the curtains around you. Oh, imaginary curtains, yeah. And she's like, it's fine, yeah, well, she's a bit drowsy. So we're going to do a full exposure of her chest. Oh, she's a funny mannequin. Okay, so we've exposed the chest, and the first thing I'm going to do is I'm going to feel her chest, yeah? So I'm actually going to put my hands on her chest, and here I'm checking for equal chest expansion, okay? I'm making sure that she's got bilateral chest movement, yeah? So if there wasn't, I'd be worried that something was going on, but she hasn't, she's got bilateral chest movement. Yeah. So the next thing I'm going to do is make sure I've got a SATS probe. So, Peace, can you please put a SATS probe on for me, please? Yeah. Thank you. So we're going to pop a SATS probe on, and whilst that's being done, the next thing I want to do is have a little look at her trachea. Is it central? Because if it wasn't central, I know that and it is deviated, I know we've got a tension going on, I'll sort that out straight away. But it is, so we're happy with that. The next thing we'll do is I want to count her respiratory rate, and this is really important, as you know from your session with Lee yesterday, because that can tell us if they're big sick, little sick, or are they okay. It also could indicate to us, especially in a post-operative environment, have they had too much opiate and they've got respiratory depression, yeah? Or are they in a lot of pain, so they're hyperventilating, yeah? So I'm going to count her respiratory rate for a full minute, not just have a look like what Lee said. I could have killed him yesterday. I gave him a bollocking after you all left yesterday for that. But yes, we're going to count it for a full minute, and I can tell you her respiratory rate is 19. So it's within normal limits. I'm happy with that. We'll document that afterwards. Is there one? There should be one. Have a little look in the drawers.
I didn't see one the last time either, I don't think.
Has it been robbed? See if there's a fake finger probe in there, maybe. But we can pretend that she's on, she's got a SATS probe on, and her oxygen saturation is sitting at 96% on 6 litres. So again, I'm happy with that, yeah? So the other thing I want to do in breathing is I want to auscultate the chest, and I want to percuss the chest. Now you have full proper auscultation and percussion sessions in your third year. It's part of your emergent care role, so by the time you're going to be registering, you will know how to auscultate and palpate the chest, okay? My advice to you would be is in your clinical placements, ask your anaesthetist, when you've got a stable patient and the drapes are up and you've got that little bit of a gap, ask if you get on with a particular anaesthetist, just ask them, can you teach me how to auscultate appropriately, etc. Because the more experience and exposure you get, the better you'll get at it, yeah? Okay. So we're going to auscultate the chest. I'm not going to be able to find a bloody stuff.
It's right there, next to the suction.
Oh, right behind me. So please do not put these in your ears. I don't know where they've been. Yeah, so just hold it next to your head, okay? So we're going to auscultate the chest, and I'm listening in for breath sounds and any additional sounds. So that could be wheezing, crackling, anything like that, or no sound at all, because that's a concern as well, yeah? But on Tina's, on this instance of Tina, she's got air entry on both sides with no additional sound, so I'm happy. So that should mean that on percussion, it should be resonant throughout, and that's our breathing assessment completed, yeah? So we'll tap on all 4 quadrants, and it's resonant, no additional sounds, yeah? So I'm happy with breathing. So I'm then gonna cover poor Tina back up, because I don't think she wants to sit there half naked for the rest of the time, yeah? So we've covered Tina up, I'm happy with her breathing assessment. And then I'm gonna start on C. So the way I remember C is start at the bottom and work my way up in like a C shape, okay? So I feel her hands initially. Does she feel cold, clammy, sweaty? Is she warm? That kind of thing, because we all know post-operative patients tend to be quite cold, even though we do our best to warm them in theatres with bear huggers and fluid warmers, etc. A lot of the time, large parts of their body are exposed to our cold theatre temperature, so therefore they do come into the recovery quite chilly. So we're just going to make sure that she's warm enough. So we're going to have a little feel, and she actually feels quite warm to touch. Theatres have done a nice good job, but we could get her a warm blanket, couldn't we, if we needed to, to look after her. And we can check the core temperature. So I'm going to check her temperature, and her temperature comes back at 36.8. That's normal, we're happy. That's actually quite a good temperature post-operatively, yeah? So she feels warm to touch, and then I'm going to move on to a radial pulse. So what do I feel, how does it feel, and what is the blood pressure? So at this point, I'm going to ask Peter, could you kindly put on a blood pressure cuff for me? So I'm feeling the radial pulse, and it feels regular. It's not bounding or anything. It's a good strong pulse. And if anything, it's pulsating a bit too much for my liking. So I definitely want that blood pressure done. I'm counting it for a minute, and the heart rate I reckon is probably about 110. So slightly elevated, but I would expect that. She's a post-op patient who might be in a bit of pain. We haven't assessed her pain score just yet. Yeah?
So sorry to interrupt you. So when it comes to the OSCE, we would obviously put these items on. We're not going to have someone to help us put them on. We're going to put them on, right?
You can put them on, yeah.
Yeah. When it comes to, are we verbalising that we're doing it for a minute and then asking for the result, or
so
we stand there
for
for a minute?
I'm going to feel a radial pulse.
Yeah.
Can you tell me how it feels and what's the rate, and then I'll give you that information. Okay.
But we say that we know we basically show we know we're going to do it and how long for, etc. Okay. Cool. Thank you.
Oh, you found it. Well done. Okay, so Peter's popped on a blood pressure for me. We actually now have a supplement. And the blood pressure comes back at 150 over 100. That's elevated.
Yes.
As per so thinking about that, we know that she's hypertensive.
Mm-hmm.
We know that she's got that as a comorbidity, yeah? Mm-hmm. So we've already got that about thinking that in our head, so we need to address that. Okay. So we don't want to be pumping her full of fluids, but also at the same time we don't want to give her anything if she isn't already on some, because most of our post-op patients are, yeah? Mm. But also she might be in pain. Yeah. Yeah, it might not be the hypertension, she might be in pain because she's slightly tachycardic and she's got hypertension, so she might be in a bit of pain, so we need to find that out in our D assessment, yeah? So continuing on to C, she's a post-op patient, so she'd already have a cannula in. I could just chuck me that cannula, please. Is that all you want? Lovely, thank you. So she's already got a cannula in, yeah, and we know she will have because she's post-operative, okay? So she's got a cannula, so we're not concerned. If we did need to take any bloods or anything for her, then we wouldn't be able to take it from this cannula because she's obviously had drugs being put through it, okay? So we would either have to do a venipuncture, or if she's got an arterial line, we can take an arterial sample. It depends on what she's got. She doesn't have an arterial line, and at this current moment in time, I'm not actually overly concerned, so we don't need to do a repeat set of bloods currently. That may change later on, but we can reassess that, okay? So moving up here, we're going to check for a central cat refill time, okay? And this is really important. So I'm just going to push down on your chest, Tina. 1, 2, 3, 4, 5. And that comes back in 2 seconds. Perfect, that's what we want to see, yeah? Whilst also looking at her chest, we're making sure that it's a nice colour, there's no rashes, we're not concerned about anything, okay? You could listen into the heart sounds if you were concerned about the heart, but none of you are going to be, so don't worry, yeah? But this is just for future reference and for your learning. And like I said, at this point, oh Sheila, you okay? I didn't expect you today, is everything alright? No. Yeah? She doesn't have any fluids running at the moment, so I would be giving her a cautious stat dose of fluid. if it's been prescribed, because bearing in mind this isn't a resuscitation attempt, so we can't just put fluids up, it has to be prescribed. So I'd want you to have a look at your drug chart and see what your anaesthetist has prescribed this patient. And I was the anaesthetist earlier, and there is no fluids prescribed. She already had a litre of Hartmann's in theatre. That's more than sufficient. Yeah, she can pass urine herself, she can eat and drink, etc. There's no need for us to flush her with fluids. Okay, so that's our C assessment. So then we're going to move on to D. So D is where we're going to assess her AVPU, we're going to assess her pupillary reaction, we're going to have a look at the drug chart, we're going to do a BM, and we're going to assess her pain at this point as well, yeah? Okay, so Tina, how are you doing? So she's talking back to me straight away. She's alert, okay? We're not worried and concerned about her in that sense. Tina, I'm just going to shine a little light in your eyes and check your pupils, my lovely. So we're checking those, they're equal and reactive to light, they're about a size 3, yeah, so I'm happy with that, okay, so that's, everything so far is normal, other than the blood pressure, and she's a little bit tacky, okay. So then I'm going to come down here and we're going to do a bedside glucose, and that bedside glucose comes back at 6.9, we're happy with that, yeah, that's again within normal ranges, so far so good.
Yeah.
Tina, on a scale of 1 to 10, 10 being the most excruciating pain you've ever felt, can you rate your pain for me? So she told me her pain, she's like, oh, actually it's about a 3, it's not too bad, tummy's a little bit bloated and you know, feeling a bit uncomfortable, but I'm okay. So we know that she's been inflated because it's laparoscopic with CO2, so she's going to have, you know, that bit of tummy pain. She could also have some associated shoulder pain as well, which is quite common when you've got CO2 in the abdomen and gas in the abdomen, absolutely. With a lap chole, with the way we tilt them for a lap chole, what else would I be potentially concerned about these patients?
Dressed where the strap is. Where the straps is.
Yeah, maybe back pressure sores and where the straps are, yeah, absolutely. But also surgical emphysema.
And you're about the gas
going to the
up.
chest cavity. Have any of you seen surgical emphysema yet?
No.
Okay, so surgical emphysema, how can I describe it? It's like bubble wrap under the skin. That's the best way to describe it. And when you push the chest, it feels like you're just pressing on bubble wrap. It's really strange feeling. Most of these patients, if they've got surgical emphysema, will also have very swollen eyes and actually won't be able to open their eyes when you're trying to wake them up anyway, because they'll be so swollen and puffy. I've only had it a couple of times, and actually it was more hiatus hernias, because obviously we're working up here, that they tend to get it. But it is possible, if they've got a little hole anywhere that we didn't know about and the gas has escaped, it is possible. So just when you're looking at your chest in C, just make sure you're looking for that. But again, your patient's not going to have that, so don't panic. Okay, so we've now done our D assessment, so we're doing E, so everything else we're going to expose, alright? So Tina, I'm just going to have a little look at the lower half of your body and your abdomen. The reason I'm doing that is because I've already checked her chest, so I know that's okay, yeah? So we'll have a little look around the head. She's got no swollen eyes, no blue lips, there's nothing there to note really. Just going to have a little look at your abdomen. Oh, Tina's now got a willy, okay, that's weird. Okay, so we're going to palpate the abdomen, and she's like, oh, it's a bit uncomfortable because of the gas, I feel like I need to pass wind. And I'm like, yeah, go for it, because that's going to make you feel better, yeah? We're going to make sure that we cover her back up. I'm just going to have a little look at the lower half of you, Tina. So I'm going to expose the legs, and I'm going to have a good feel. So she will have had TED stockings and probably Flotrons on at the same time anyway. If she's just got the TEDs or whatever, just have a good feel of her legs and have a good look. If she hasn't had any, has she had Flotrons in theatre and why they've been taken off? Yeah, so we need to be questioning that. So we'll just have a really good feel, have a little look in the bed, make sure there's nothing to note, and we'll do that again on the other side as well. She's done a full exposure of your patient, okay? So we've done our full A to E, and we know that she's tachycardic and she's hypertensive. Her pain score is low, so actually it's probably not associated to pain, so therefore we need to treat, okay? But we don't have prescribing rights and we're not doctors, so we can't do that without a doctor present. So then I'm going to call for my anaesthetist. So Peace is my anaesthetist. Don't worry, you're not going to have to say anything, you're just going to have to listen to me waffling. Oh, no worries. It's okay. So, hi Dr. Peace.
Hello.
I'm so glad you've come. So Tina's just come, she's a post-op patient, she's had an elective laparoscopic cholecystectomy. God, that's a mouthful on Friday morning.
Yeah.
It was uneventful, routine procedure. She had propofol, fentanyl and ondansetron on induction.
Yeah.
She had a litre of Hartmann's throughout the surgery. She is a known hypertensive and ASA2, otherwise fit and healthy.
Yeah.
I've taken over her care. I've completed a full A to E assessment, which was unremarkable aside from a heart rate of 110 and a blood pressure of 150 over 100, I think I said. That's what happens when you make it up on the spot. You forget. As she's a known hypertensive, she omitted her dose this morning because obviously she was coming into surgery. So I would recommend that we give her some labetalol to bring the heart rate and the blood pressure down. If you could prescribe that for me, please.
Yeah, no problem.
Perfect. So they'll then add that to the prescription chart for you, and you're then going to go ahead and document your full A to E assessment. So keep it down to the key points. Yeah. And then keep it. I've lost my train of thought now.
You're going to document it A to E,
To
of
the
everything you
point.
found.
So document it, but keep it to the point. Don't write hundreds and hundreds of lines. Yeah.
Yeah.
That's where I go
keep
wrong,
it
is
to
the
the point.
writing.
Yeah, it needs to be
Precise.
Yeah, precise but short and sweet.
Short and sweet, yeah.
Yeah, because if someone comes up and there's a full massive essay on a page, they're not going to be interested in reading it all, and actually they then may miss key points of care.
Yeah.
So that's why you try and keep it to the point as best as possible. So airway, clear, or patent, how you want to write it. Breathing, unremarkable. Rest rate was 19.
19, yeah.
Sats of 96% or 6 litres of oxygen. Next. Yeah, auscultation was clear, palpation resonant. C. Cannula in situ, warm to touch, radial pulse palpable, heart rate of 110, blood pressure of 150 over 100, central cap refill of 2 seconds. Done. D. What did we find in D? E. And then you would document S-bar handover given to anaesthetist, labetalol prescribed for hypertension and tachycardia. Yeah?
Yeah.
That's your OSCE done.
With the cannula, do you also put what size and if it was clean
We
or
didn't put
anything?
it in, so no.
Okay, fine.
We didn't put it in.
Okay.
And we haven't used it. If you
Okay.
go to use it, which will be when that will be your year 3 meds management OSCE, because you're going to be giving drugs to a patient as part of your OSCE in year 3.
Yeah.
So then I would expect you to document that the cannula site is clean, dry, you cleaned it beforehand, etc., etc. Yeah.
Right, okay.
Yeah.
Yeah.
But not for this one, because you're not
Okay.
actually physically going to give anything in this OSCE.
Okay.
So at this point, I would be asking me, I suppose, because I'm the candidate, about the drug that I'm going to give. So you've requested that I give labetalol. Can you tell me how that's metabolised by the body? Can you tell me how it's excreted? Do you have any concerns with what I'm about to give with all the other drugs that she's had today? Yeah, those kinds of questions. Okay, about the 2 drugs that I've told you to look into. Okay.
And all the
Yeah.
other drugs will be what you mentioned now. Propofol or
No,
regular.
the 2 drugs you
No,
said.
no,
the
no,
two
no,
drugs
no,
you
no,
said.
No, interactions as she said in theatre.
Yeah, so the 2 drugs I've given you for the OSCE, I'm going to ask you questions about those. So you're going to think about, you're about to give them, will they interact with any of the drugs the patient's had in the last couple of hours? So that would include like propofol, Remy, whatever they've had in theatre, which I will give you that information. Okay?
That's what I'm about.
Oh, okay.
Yeah?
Okay.
Okay. So,